Good evening. My name is Jim Greenblatt, and I'm looking forward to talking this evening about what I call some of the hype and the hope of folate and the MTHFR testing. The genetic testing has really taken in traditional psychiatry, as well as through the integrative psychiatric community. And I believe there's incredible potential to understanding how genetic vulnerabilities can help dictate treatment. But I also see every day now people coming in who have genetic testing and seeing that the MTHFR test are the answer to all their chronic medical and psychiatric problems. So let's try to explore how we can use genetic testing. This is a quote from Dr. Snyderman, who retired from Duke University, and just using the term integrative medicine, he says, what we now have is a sick care system that is reactive to problems. The integrative approach flips the system on its head, puts the patient at the center, addressing not just the symptoms, but the real causes of illness. It is care that is preventative, predictive, and personalized. And that, to me, is a beautiful description of what the potential role genetic testing can provide, as well as understanding how that genetic liability may lead to vulnerability to illness. Modern medicine is one of the most spiritually malnourished professions that ever existed, and we're looking to kind of use all of our tools in our toolbox to make a dent. And tonight we're going to focus on depression and mood disorders, and where folate and genetics may play a role. Depression is one of the most serious and costly health problems in the world today. It is the second longest number of days lost to disability. 15% of adults, severe depressed mood, and 15 to 20% will become chronically disabled or commit suicide. The third leading cause of death in our youth, more than many of our chronic major illnesses, including AIDS, cancer, combined. One of the more frightening statistics, in the next couple of years, depression will be the leading cause of disability worldwide, more than any other chronic illness, cardiovascular, diabetes, cancer. Depression will be the world leading cause of disability. We know it's multifactorial in nature, that the kinds of things we'll be talking about would be this genetic vulnerability, early life adversity, multiple factors in the environment, weight, and inflammation, all affecting all having epigenetic roles, if you will, and affecting the course of treatment. Our current model is suboptimal and looking at folate as a solution. Psychiatric testing is a guessing game, if you will. As clinicians, we ask a bunch of questions, and we arrive at our diagnosis with symptom relief. On the right, you see psychiatric treatment is based on this symptom checklist, and our medications or our treatment are just based on the symptoms. Someone is depressed, we give them an antidepressant. Someone is anxious, we give them an anti-anxiety medication. If that works successfully, that would be great, but treatment for mood disorders is marginal. Versus our medical model, where we can actually measure the physiology, look at something objective, a chest x-ray, a blood test, and then we can treat based on that physiology. So we just keep adding names, and this is up to the DSM-4 We keep a 340% increase in the number of diseases. I don't know of any medical specialty that keeps adding names without etiology, and DSM-5 recently came out with more names. So the part of the problem in traditional psychiatry is this polypharmacy highway that we are pretty much stuck on. We prescribe one medicine without stopping the first medicine, add a second medicine, and polypharmacy is now the norm. Average psychiatric patients taking over 3 psychotropic medications. But some of this we talked about earlier. The relapse rate is common, almost 40%. We have 20% incapacitate or commit suicide. And then some of the more dramatic information that's come out over the past few years is the vast majority of patients treated with these antidepressants have residual symptoms. Ask your doctor if placebos are right for you. Our medications for depression are getting harder and harder to study as a placebo response is increasing. There's almost a 50% improvement with placebo. If we gave our patients sugar pills or M&Ms, if you will, it'd be 35 to 45% chance of improvement. And this placebo response is increasing every year over the past 15 years. So it's harder to find medications or for drug companies to actually want to study antidepressant medications because they can't beat the placebo response. So our pharmaceutical companies are looking at what's called augmentation strategies. What can we do to add to the antidepressant? And you've seen the commercials, and there's also significant nutritional research on augmentation, augmentation strategies for antidepressant medication. We're going to focus on folate. Here was the original study looking at this vast majority of patients, 67%, having symptoms even after being treated for depression. So what is this concept of treatment refractory or treatment-resistant depression? And that's what we're going to try to tease out through the course of this evening. And I'm just going to go around this wheel for a minute because I think it's really important. Starting from the top, the correct diagnosis. Oftentimes, people are providing symptomatic relief and not looking at other medical, hormonal, nutritional, and or psychiatric diagnoses that can be confused with depression. Comorbid medical conditions. We know that heart disease, cancer, many chronic medical illnesses have high rates of comorbid depression. Adequate dose and adequate duration of treatment. Common concern is patients saying, I'll take an antidepressant, but I just want a low dose. Well, it's like being partially pregnant. There's no such thing as a low dose. There's a therapeutic dose. And again, based on genetics, that varies from individual to individual. Compliance is a common concern with medications, primarily due to side effects, severity of illness, and then the last one, comorbid psychiatric conditions, not treating a comorbid substance abuse problem, attention deficit disorder, anxiety disorder impairs the successful treatment of depression, be it with medications or nutritional therapy. I think this is a really critical part of why integrative therapies are so critical for the treatment of mood disorders is a side effect profile that's often ignored for many of our patients. All the antidepressants have black box warning for increasing suicidal risk. The sexual dysfunction is quite concerning, and 60 to 70% of the research, many people feel it's much higher and closer to 90. But the most concerning might be this concept of emotional numbness, this inability to have complete range of emotions, to feel the joy of a wedding or a birth, or the sadness of a death or a tragedy. So common complaints is, I just don't feel like crying. And to me, that emotional numbness is a cultural tragedy, and it impacts our ability to have real joy, fall in love, and have intense feelings of happiness. 1,800 individuals studied in a research article this year. So the new model that we've been talking about, over many years now with our functional medical testing, looks at underlying causes of depression. And these are just some of the few, and we're just going to talk about one tonight, and that's folate and genetic testing for folate. And I'm a firm believer of almost 25 years of practice that integrated nutritional biochemistry will enhance recovery, prevent relapse of this tragic illness. We talked about genetics, and most of the risk for depression is likely environmental. So we have this unique kind of environmental and genetic interaction, and we call that epigenetics. So I talk about biochemical individuality a lot in terms of nutritional support and doses of nutrition, but here's just a sample of our individual responses to antidepressants. If you can see, each color is a different person, and that tremendous variability is across all lines. So why is folate such an important thing to understand? One is that there are many, many aspects in our environment that contributes to folate deficiency. The vast majority of psychotropic medications, all of our mood stabilizers, some of our antidepressants, Prozac, and many of our antibiotics, oral contraceptives, metformin, and then you see under lifestyle alcohol as well. So a large number of things that we take in daily affect folate absorption and utilization. Disease states, we are kind of epidemic with chronic GI problems, from celiac disease to colitis and Crohn's, and these all affect absorption of folate. Smoking and inadequate nutrition, aging, our diet, and then what we'll talk about is the genetic risk factors, the MTHFR gene, and obesity. It's become increasingly clear that inflammation due to fat cells contributes to higher needs for folate. And obesity is probably not the right term, because a BMI over 30 is considered overweight, but not even obese. So small weight gains do have significant effects on inflammation. When we talk about folate metabolism, there are many steps that the body goes through to convert a folic acid, which is actually synthetic. So folic acid is made in a lab. It's a form of folate that is not naturally found in our food supply. It was discovered in the 40s, and is how we fortify food and add supplements. It's inexpensive and cheap. But the last conversion, if you will, here on the bottom, is to L-methylfolate. And what's important is L-methylfolate is the only form that crosses the blood-brain barrier, and it is the form that is, the conversion to L-methylfolate is what is impaired in genetic variants of the MTHFR gene. one of the important kind of take-home points is we're going to talk a lot about folate and folate deficiency and its impact on mood disorders and health. But it is uncommon that we see folic acid deficiency, as our routine blood tests look for all forms of folate. So that would be synthetic folic acid as well as all the various forms, converted forms of folate. So oftentimes the serum levels are quite high, even though the active form is not crossing the blood-brain barrier. And here you see on the left of the slide, folic acid, the synthetic version that's added, that's fortified and added to our food supply, is thought to actually block the receptors in the brain. So they fit the receptor, but they don't enable L-methylfolate to cross the blood-brain barrier. And this is really important because when we look at serum levels, we have this false sense of security that we have normal folate levels, and it's clear oftentimes that we are deficient in the active form of folate in the brain, L-methylfolate. We've known for years that folate's been associated with depression. Here's just a simple diagram of that L-methylfolate providing through SAMe as the methyl donor, providing the enhancement of synthesis of all the major neurotransmitters, dopamine, norepinephrine, and serotonin. So without adequate L-methylfolate crossing the blood-brain barrier, unable to methylate the major neurotransmitters. This was what's called a meta-analysis, looked at 11 studies over 15,000 patients, very, very high correlation between folate levels and depression. Also seeing good research looking at folate and bipolar disorder. This was 88 patients, double-blind, placebo-controlled trial. Folic acid added to the Depakote, the valproate, improved symptoms of patients with bipolar. Again, there's been an explosion of both research and interest in looking at L-methylfolate. Things shifted in 2007 because L-methylfolate wasn't sexy enough or didn't catch the attention of our psychiatric colleagues. So this was an article about folate using the term tri-monoamine modulator to help describe the conversion to SAMe to support synthesis of all the major neurotransmitters. So I just want to share with you a few studies of how important folate is. This was in folate and response to the antidepressants. And here 55 adults, low serum folate was associated with poor response to antidepressants. It was 7.1% compared to 44%. So low folate, poor response. And then here, a related study, major depressive disorder, 20 milligrams of Prozac for 8 weeks. If there was low folate, there was a significant lack of response. Again, it wasn't related to dietary intake. This was the first study that looked at folate augmentation to Prozac, and with a tiny dose, for 500 micrograms per day, adding folate, this was folic acid, to the Prozac, showed a significant improvement. Folic acid simple, improving the antidepressant action of fluoxetine, and the conclusion was likely other antidepressants. Here is, I think, a dramatic study by the same group at Harvard Medical School, Mass General Hospital. Patients were treated for Prozac 20 milligrams a day for 28 weeks. And patients improved, but the relapse rate was dramatically different. We see a relapse rate for patients with low folate, 42.9%, almost half of those patients adequately treated with the antidepressant relapse after 28 weeks, and those who had normal folate, the relapse rate was 3.2%. And here's one of many, many more studies looking at low folate in geriatric patients, which is a common area we see deficiency in folate, lower folate associated with severity of depression, psychiatric illness, and longer psychiatric hospitalization. So again, we've had this research for a long time, but to summarize, it's pretty significant correlations and research corroborating low folate increased incidence of depression, low folate poor response to antidepressants, low folate higher relapse rate, and folate supplementation enhancing the effect of the antidepressant. The good news about the high-dose folate pharmaceutical that has come out, there's been now more and more research looking at this supplementation as an augmentation strategy for the antidepressant. These are some of the folic acid researches, adding 2 milligrams of folic acid, increasing folate levels, is easily taken, inexpensive, and safe. My recommendation is actually L-methylfolate, and I'm recommending as maintenance 3 milligrams per day. So let's shift to this genetic link, and again, there's lots of hype, and there's certainly a tremendous amount of hope. So it's quite clear that folate's related to depression and mood disorders. That's 30 years of research. And the genetics kind of helps us untangle some areas to enhance treatment. So we have 3 different versions of the MTHFR gene, and these polymorphisms, as I call, increase risk for depression. So the CT variant, individuals with that have a 1.36 times greater chance of developing depression, and the TT genotype, individuals have twice the risk of getting depression. So here you see the percentages in the population. The little figures on the right kind of just share as the T allele increases, one has becomes more vulnerable to many illnesses. CC is a normal variant. CT, 56% of the population. The TT is the twice the rate of depression. I think it's pretty safe to say that T is for trouble. So any T allele does set you up for a number of risk factors that we'll talk about in a minute. Whenever we talk about genetic testing and genetic liability, it's really important to understand that this is not genetic destiny, it is liability. It doesn't mean that if you have the TT variant, that you will be depressed. It means you are markedly more vulnerable to depression, twice the risk, and that's when the environmental factors play an important role in the genetics, decreasing the 5-MTHFR genotype. It's just another example of what these genetic polymorphisms look like. The CC variant, this was a test for DNA repair, but I think it's a nice kind of image of what might be needed clinically. So for the same amount of DNA repair of 400 micrograms of folic acid would require someone with a TT variant, because the conversion is so slow and to the L-methylfolate that they would need 3 times the amount of folic acid. This is a really, really important study looking at early life adversity. and the relationship between the MTHFR genes. And the graph looks at depression inventory as well as early life adversity. And you can see as the number of adverse life events increase, that the total depression scores increased. And if you see the CT and TT are not too far apart. So again, T is for trouble, the vulnerability is higher. There's a strong association with depression and obesity, and I think it's important to kind of understand that relationship. We know that increased body weight is associated with a decreased response to antidepressants. Increased body weight increases the risk, severity, and chronicity, and major psychiatric medications obviously generate weight gain, and obese individuals with depression have a much higher risk of developing metabolic syndrome and diabetes. One of the important variables is that the relationship between inflammation and a very powerful role that plays in depression. When we talk about obesity and adipose tissue, here's kind of a very complicated example, but if you see that the enlarged abdominal fat cells cause increase in all the cytokines and CRP, which leads to this inflammatory response. And this inflammatory response has clearly been associated with depression and poor mood. So we've talked about this in the past, but we know that patients with depression have higher levels of inflammatory cytokines and lower levels of the anti-inflammatory cytokines. And all of our treatments for depression, be it exercise, relaxation, dietary, or medications, or even ECT, have been shown to decrease these inflammatory states. This is one study, the last bullet, where Zoloft, an antidepressant, decreased inflammatory cytokines in depression. A lot of the pharmaceutical companies now are looking at inflammatory, anti-inflammatory medications to treat depression. The mechanism is relatively simple. The cytokines induce this IDO enzyme, which degrades both tryptophan and serotonin. So we have this active enzyme produced from these inflammatory cytokines. It degrades serotonin and its precursor tryptophan, so less availability of serotonin, less availability of melatonin, and that's why sleep and mood disorders are so interconnected. So inflammation has a profound effect on depression, and we've known this for a long time, and the multiple opportunities are both nutritional, and we'll talk about folate. Other anti-inflammatory treatments effective for depression are things like magnesium, omega-3s, curcumin, and again, many pharmaceuticals are looking for this kind of approach. So a physiological process activated in a similar manner by a diverse range of environmental factors. All of these are depressogenic. So we're not going to have time to go all the various causes of inflammation in the body, but it's anything from our lifestyle to sleep deprivation to chronic infections that could be candida, Lyme, Clostridia, food allergies, all the inflammatory processes that are at play, both lifestyle, dietary, all have the potential of supporting a depressogenic environmental influence. Here's another summary of this inflammatory cytokines, increase in the enzyme, and you see low tryptophan, low serotonin, serotonin decrease, and we have our sleep disturbance, and we have decrease in melatonin. And then also this increase in quinolinic acid is also the direct result of converting tryptophan to quinolinic acid. It can be picked up on the organic acid, and then we have increased glutamate and destruction of neurons. So where does folate fit in? Well, this increased inflammatory process, you can see here, causes an increased demand for L-methylfolate. So inflammation, oxidative stress takes its toll on the precursor BH4, which requires L-methylfolate to support the SAMe for the synthesis of all the major neurotransmitters seen. When I shared with you, L-methylfolate is not a great tool. Folate levels are not great in the serum. We look at RBC folate. We have some functional markers. But homocysteine is by far one of the easier blood tests to look at as a functional marker for folate deficiencies. And homocysteine is also associated with both depression and cardiovascular disease. This was a study that showed that increased homocysteine levels, patients with increased homocysteine had lower serum RBC and CSF folate. So it's really important that these were CSF studies, cerebrospinal fluid, and we were able to show low levels of folate as well as the SAMe and the metabolites of the major neurotransmitters. Again, just another example. We also see this with B12, but serum levels are not adequate and don't always reflect CSF levels. So elevated homocysteine is an important marker to help us assess that. This was an old article looking at this using homocysteine as a marker and a way of understanding depression, and the concepts are quite simple, where elevated homocysteine as a marker of folate, or we could substitute B6 or B12 deficiency, poor methylation, decreased SAMe, and depression. And then here folate of B12 or B6 supplementation is going to decrease homocysteine, increase SAMe, and enhance clinical response. SAMe is also an important adjunctive tool for the treatment of depression. And these are some of the earlier studies and books written about SAMe. The history was a little dramatic when it came over from Europe. The original studies looked at IV intravenous use of SAMe, which showed pretty dramatic responses. In this country, over the years, we have been able to develop a supplement that does pass through the acid of the stomach and so absorbed. It's a powerful tool in the treatment of depression. And like folate, we have some good studies. This is just looking at some of the trials, and the most important side effect I can share with you is mania. So we would not use SAMe in patients with bipolar illness. We can see agitation and mania. But this was a relatively recent study, again, looking at SAMe augmentation to the antidepressant. And here we have a 6-week double-blind placebo-controlled trial, which means the dose was 1,600 milligrams. So many individuals say SAMe was not helpful, but they've only used 200 to 400 milligrams. The therapeutic doses in all the studies have been 800 to 1600. Occasionally for mild depression I've had success with 400 or 800, but oftentimes we would need to increase the dose. And here, the SAMI augmentation compared to placebo, the response rates for depression was dramatically different, and the remission rates also were dramatically, statistically significant better on the SAMI. So the use of L-methylfolate, I think, has been an incredibly powerful tool. There's so many of the patients that we're seeing that are high risk for folate deficiency. I've listed some of these here: alcohol use, adolescents not getting adequate intake, all the medications that I shared with you, the anticonvulsants, metformin, birth control pills, alcohol, our geriatric patients, and much of my world is eating disorder patients who might have normal serum folate levels because the toast or the cracker that they might be eating would have fortified folic acid, but without adequate zinc in particular, it's hard to cross the blood-brain barrier. And then what we try to talk a little bit about is this MTHFR variant. In my experience, the hype is that adding L-methylfolate is not a cure-all for depression or many other chronic illnesses. It's usually part of a comprehensive metabolic approach, looking at deficiencies in nutrients, hormones, and environmental and toxins and sources of inflammation. I have found success adding folate to antidepressants, particularly with the CT or TT variant, and I've had success supporting this genetic variation, adding L-methylfolate. We have prescription L-methylfolate for 15 milligrams. It's unclear to me that that is required to provide a therapeutic benefit, and the vast majority of the time I'm using 3 milligrams of L-methylfolate. The first slide I shared with you concepts of personalized treatment by looking at our genetic markers as well as preventative treatment. And I think that folate is a good example, and here's a study that looked at the elderly and folate and prevention. This was daily intake over 7.5 years. Total intakes, which included supplementations of B6 and B12, with a decreased likelihood of depression on follow-up for 12 years. Each 10 additional milligrams of B6 and B12 were associated with 2% lower odds of depressive symptoms. So here, and we have homocysteine studies demonstrating a very similar thing, that we begin to talk about models for prevention by monitoring homocysteine levels and adequate dietary intake of B6, B12, and folate supporting methylation. So what I wanted to share with you, we'll have a little time for questions, is that depression is not a Prozac deficiency, that we need to understand the underlying causes, and there could be many, and there could be many areas that we're looking for. And then part of what I wanted to share with you is that we've got to stop taking a single shotgun approach. Over the years, we've blamed parents, we've blamed patients, we've treated symptoms, and what I urge you is to not treat a lab test. So if you are fortunate enough to be able to do genetic testing on the vast majority of your patients, it is not necessarily the cause of an individual's depression. We're talking about a T variant in over half the population. So we don't treat a lab test, we treat a patient. And by treating a patient means we're hearing their story and understanding that genetic environmental influence. I touched on the fact that these variants, these genetic polymorphism, MTHFR, is dramatically affected by early life adversity, so getting a history of trauma or stress, and then also weight and obesity, so BMI over 30. So the response rate to elevated BMI and early life adversity is dramatically better with these MTHFR variants. The tremendous neurochemical individuality, not only in how we metabolize folate, but in every aspect of our neurochemistry. It has to do with our history of psychiatric illness, how we metabolize drugs, and how we metabolize our neurotransmitters, our receptors, and these are all genetically determined. So we have this unique opportunity. Besides the MTHFR gene, we look at COMP genes and MAOIs and how we metabolize dopamine and serotonin. Provides a tremendous amount of information about who the individual is, what genetic biological vulnerability they bring into the environment. So if we can target these biochemical imbalances to enhance these genetic vulnerabilities, always focusing on remission and recovery. And again, mental illness being seen as multiple areas of physiology. The MTHFR variant might provide some support, but if I'm not looking and seeing if they're B12 deficient, vitamin D deficient, or not looking at Lyme disease or Candida, then we're not getting the full picture, and adding L-methylfolate will not be sufficient. And if we do find the cause, then we can use words like cure. I gave a talk for a supplement company a number of years ago, and I used a slide similar to this saying that depression can be cured if we find the underlying cause. And the case example was a celiac patient who was profoundly malnourished due to malabsorption, and the lawyers for the supplement company would not let me use the word cure because they said we don't have a cure for the treatment of depression. But I think many of you know that if we do get to the underlying causes, we can use words like cure and remission. So thank you for your time this evening.